Thank you very much. And I think we're back in action after the lunch break. So I would like to invite all the chairpersons. Khalid Wahid Sab. So can you please take the chair? Tariq Khan Sab. Khan Sab was here. Yeah. And Rao Rashid Kamar Sab. Basically, we'll be sharing our cases, our initial experience with Faricimab, and I'll be showing you a couple of my cases, uh, some of the troubling cases, some of the chronic cases, which were not responding to other therapies. And once this drug came, we started using this drug, and some of the cases improved, some didn't. And I just wanted to share what I felt in the last 6 to 8 months of this treatment. Of the last 1 year, we had a couple of cases, but in the last 4 or 5 months, actually, now the picture is getting a bit clearer that which patients are going to get this drug. So my first case, DME case, and in Pakistan, DME is getting endemic. Every second or third person is coming with diabetes. And the problem is they'll tell you the same story. जी हम घर में शुगर चेक करते हैं बिल्कुल कंट्रोल होती है. And the issue is the moment you get there HbA1c पता चलता है जी 8 9 10 15 जा रही है और उन्हें सुबह 8 बजे चेक करनी होती है. 8 बजे सबकी कंट्रोल होती है. किसी ने आज ये नहीं सोचा 12 बजे 2 4 बजे कंट्रोल है कि नहीं है. So this patient had about 13 injections. Right eye was 660, left was 612. 13 injections in the right eye, and but still the vision was not improvement, and we shifted to Bismo, and still I'll just show you the OCT. So this is how he started. So pre-op, we get the same. We are following the same protocol: 3 loading doses, and then monthly till improvement occurs, and then we go to 3 monthly. And first 3 injections, hardly any improvement. Then we started going on to monthly injections, and look at the OCTs. Slowly, they started improving. But again, at the end of 12th injection, vision is still there, 624 partial, and that's it. Even after the 12, 13 injections, the vision has not improved, but it has become stable on monthly injections. The moment we skip an injection, the edema goes up. My second case, age-related macular degeneration, patient presented with 660 vision, had been on monthly anti-VEGF for the whole 1 year. And the problem is the moment I push up the gap, then the edema goes up. So again, had 3 loading doses every 3 months, but now at least the vision is stable. Previously, with the previous anti-VEGF, even with the monthly dose, the visual acuity was not stable. But now, look at the first pre-injection, post-injection third, edema starts to settling. But every 3 months, again, the edema comes back. So this is happening after every month. And now, started every month, then we started increasing the interval. Now you can see the CNV has regressed, but after the moment third month पूरा नहीं होता, patient comes back, जी पानी आना शुरू हो गया. So we are on 3 monthly now. My third case of age-related macular degeneration. So again, recurrent AMD requiring anti-VEGF, vision was 660. Now, with the help of Bismo, we have shifted to 3 monthly Bismo after the first 3 doses, and the vision is stable at 612. So one of the happiest patients I've seen, because previously the vision was not improving at all. So again, you can see the pre-injection CNV injections, and now on 3 monthly injections, the vision has stabilized. But the moment you are going to extend the gap, the fluid will come back or the CNV will become active. Fourth case, again, age-related macular degeneration with pigment epithelial detachment. A patient we had CNV plus pigment epithelial detachment. Multiple injections since 2019. Imagine somebody having monthly or after 3-4 months were getting an injection since 2019 and came to us कि जी मेरी तो इतने टीके लगे नजर ही कुछ नहीं हो रहा. Shifted to Visno, initial 3 doses, and now again monthly doses, but the vision 636. So happy to have some vision back. So with PED, 3 injections, pre-injection, post-injection, third injection, getting settled, and then dramatic improvements. But anatomically, the fluid has gone, but physiologically, the damage has already been done. But still happy from 2/60 to 660, good improvement of vision and staying stable there. And lastly, another case of DME. So a lot of DME in my practice and AMD. So again, chronic DME. Vision is 618, 612, multiple injections, प्रीवियस कई जगहों पे जा चुका है 3 साल, लेकिन अगेन वही प्रॉब्लम, शुगर कंट्रोल नहीं है. HbA1c 2-3 दफ़ा कराई, शुगर गेट्स कंट्रोल्ड, नाउ स्टेबल एट 6-9. So again you can see pre-op, third injection, fourth injection, getting stable, now on monthly injections. A problem yahi hai, the moment you start extending, the edema comes back, even with good control of diabetes. But previously with the other anti-VGF, even this, you could not get the monthly improvement. Vision would staying at 618, 624 would not improve. So in my limited experience, it's got a very varied outcome. The promise made by the company कि जी wonder drug है, एकदम सब कुछ dry कर देगी. Honestly, I have not seen that in my chronic cases. It works, no doubt. A lot of failed cases to other anti-VGF, it has done wonders. But again, very variable response. Like, I will not say this drug is the drug the moment you will give it and you forget about everything. No, you have to follow it. And then majority of the cases it will work on 3 monthly. But yet I have cases जिनको every month अभी भी लगाने पड़ रहे हैं. So I don't know, it's just I think 1.5 year हुआ है हमें. अब पता नहीं कितनी देर के बाद जाके they go on to 3 monthly dosage, but still there are cases जो 3 months में चले गए हैं. Not a lot of them, but still improvement हुई है, but on monthly doses. So still looking for the perfect drug. Not every drug is perfect, but at least इसका hope ये है कि at least whenever new drug comes, getting better results, and I think with time better drugs will come. They'll keep on improving their salt, but it is safe, effective, and I think worth a try in chronic patients which are not improving to other drugs. And as a primary drug, now I have got my confidence, so a lot of patients are getting it as a primary therapy as well. Thank you. So for the next talk, I'll ask Khurram Sahab for his talk. Ji. I think we'll take questions at the end of the session.
Okay, so thank you very much, Roche, for this symposium here. Vabysmo, although worldwide it's been used for many years now, but we were introduced to this one. We were supposed to get it last year in February or January, but administrative problems with the government, I mean, it took quite long. So we started this in November. So from 1st of November, it was available to us. And obviously, before we went on to this one, we had a little experience with another salt, which was being used, and we went through studies and everything, and that one was causing some inflammations in the eye. So we were very skeptical and careful about this. So obviously went through studies, attended conference and everything about Faricimab, internationally as well. So then, after looking at all those, we were confident. I remember we attended those sessions. Qasim and myself and Khalid was there, and Dr. Nadeem Riaz and so many others. So we started with AMD, wet AMD patients, and both treatment naive patients and patients who were on something. So we switched them over to this. Not all of them, only those who were becoming chronic or not responding satisfactorily. So then we went on to add diabetic patients, DME ones, and some of them were PDR patients as well with some macular edema, and pure PDR, peripheral one without macular edema. We kept using aflibercept as we were using before, but now I'm slowly shifting to that as well. And then finally, the last one added were vein occlusion patients. So approximately, I had little time to prepare this, so we couldn't count all those, but there were about 300 injections given in one of Faricimab. So half of them were naive and half of them were switched. So out of the switched, out of 300 patients, only 3 I had to go back. So one was on Patezra, and so we went back to that, and 2 were Eylea patients. We went back to those ones, and so why were they? Because some of them we couldn't find any difference, and some of them were showing less response with the previous therapy. So we changed them, and one after giving this injection, I found a little bit of inflammation in the eye. Although I don't think, although literature says that some patients can get a little inflammation and some vitritis, some AC cells, but I don't think it was this because the patient also had some episcleritis. So it was just probably, uveitis coming with that, but we stopped that and all the inflammation went away with posterior subtenon Kennicott and some topical steroids. And so that patient is getting Vabysmo in the other eye, but for this eye, we are keeping aflibercept. So earlier impressions were, first few months, that definitely it was stronger and faster because the kind of response we used to get with the other injections, we used to get them in 3, 4, 5 months. And whereas I found that this was giving those results in 1 or maybe 2 months. So then few 6, 7 months later, now I can say that it's stronger, faster, and even longer acting. So the other thing, common things which are found after these injections, that there's a tachyphylaxis to treatment, and usually world over it's called 20%. But in these 13 months, we haven't found any. Whoever is giving response is giving response. Then RPE tears, very common. 10% is a big number. But with this, I think I have maybe 2 or 3 patients where I can document that there was RPE tears, not more than that. So that's much less than that. Then, especially in diabetics, or even in the others, there's an element of fibrosis which is related to these injections. And that was found to be much less in this one as well. Probably because of the Ang2 receptor blocker, because that's anti-scarring, anti-inflammatory and anti-scarring. And we found that amount of ERMs and other TRDs with other injections, actually I saw ERMs disappearing with this over time. So that's another plus point. And retinal atrophy, again, with AMD patients and PEDs, once they settle down, you get a geographical atrophy, much less with this one. So I'll also show you a few patients, and it's kind of a happy story here. This is a lady doctor who only received 1 injection. She's presented with 612, and she got 1 injection, and this. Where is this? Anyway, the upper ones are the pre-injection ones with PED and their subretinal fluid, and the lower one is just after 1 injection and 5 weeks OCT. So there's quite a lot of resolution here. Same patient, if we look over here, that's also this one over here. You can see that there's this dead space fluid. Now this fluid is usually a dead space fluid because you can see the angle of the PED. So this usually, it's not easy to get rid of this. It can only go, if the PED is settled, then this will go, or sometimes the retina stretches over there and then it goes on to that space, but it causes micropsia. And the other is if the PED becomes scarred, then this fluid will go away. But so this does not show activity, just to mention here. So another patient had 3 injections of Eylea, a month apart, and this was after 3 injections. And I saw previous OCTs as well. They were not good quality, done elsewhere, but it was similar. 2 injections, 5 weeks apart, and you can see the result here. Going on, then there were some patients of vein occlusion. Now I have a habit of, if there is some blood around the place, it always causes scarring. So I usually tend to go with PST Kennicott as well, with anti-VEGF. So as you can see, this one, Vabysmo with PST Canacort. 6 weeks later, another Vabysmo. 4 weeks after. So 2 Vabysmos, 1 Canacort originally. Beautiful result. But we should keep in mind, and we should always tell them that this will recur. Vein occlusions will give you, a few recurrences over 2-3 years. So patient should be ready to get more injections. Similarly here, 741 microns, huge. Vabysmo with Canacort. 5 weeks later, again Vabysmo. 3 weeks later, OCT picture 231 from 741. So again, wonderful result. This was only after 1 injection with Canacort, and it went down. Now there still are cotton wool spots and things around, but so that's why more treatment will be required, and hopefully they'll go as well. Again, Vabysmo with Canacort, and 6 weeks later another one. 2 months later another one. You usually try and increase because as we have seen now that yes, what they claim is true, that Vabysmo, if you want to continue, it can last for 4 months. So it can give you 4 months gap easily. So we always try to increase the interval. So this is a patient of CRVO, 2 injections Vabysmo, 6 weeks interval, 3 months after second injection, before thinking about another one. So very good results. Now again, same here, Vabysmo, PST Canacort, and you can see the result here. Again, similar, nothing unusual here, but just that after after a little interval, this started recurring, and so obviously we'll have to treat again. This one I did not give Canacort and just Vabysmo because there was a little concern of pressure, and so 6 weeks later, it is better. It has improved, but the next one I will give maybe next week with Canacort, and then we'll see the pressure and swelling and everything. Again, 2 Vabysmos, and this is the result. This is without Canacort. Now coming on to wet AMD, again we got good results. Persistent fluid after multiple bevacizumab, 636 shifted. It was so monthly bevacizumab this patient was getting, shifted to Faricimab after 1 injection. Vision improved from 636 to 612 plus, and so obviously will require more, but there is improvement. And so sometimes one is enough to give this improvement. Only 1 Vabysmo was given and observed because of lack of funds. After that, we could not. I wanted to give more, but the patient could not have more anyway. We contacted us later, and we got another OCT done. And still, after 7 months of 1 injection, this one is holding. Will cause problems and will require treatment, but that's how it is. This one, this is not my patient. अच्छा तभी ये मिक्स है, ये मैंने एडिट की हुई थी, इन्होंने अपनी वाली डाली है. देखो मैंने तो अपनी वाली दी हुई थी, उसमें मैंने तरतीब फर्क लिखी हुई थी. चलो वो तभी तरतीब गड़बड़ हुई हुई है, मिक्सर हुआ हुआ. Anyway, this is not mine, but I wanted to show you this because this patient, 82-year-old patient, previous injection of aflibercept, 57 in the right eye and 18 in the left eye. So this is right eye and this is left eye. And after 15 injections, this was the situation. 57 and 18 injections. This single shot of Faricimab, 4 weeks post-injection. See the difference. 612 and 66. So from 612 to 66, 69 to 66. So this is what it is. It is showing this response, and this is another switch patient. 6 injections of aflibercept, and gap after that, we gave Faricimab. After 1 injection, that fluid is gone. So with aflibercept, it was improving, but then there was a gap, so it came back with one injection. This is how it is, and let's see how this one behaves. Again, similar case, AMD, and with these injections, I won't bore you with this because, again, this one, dozens of anti-VEGF, already had dozens of anti-VEGFs, never improved beyond this. And so 3 Vabysmos, 1 month apart, and fluid went away. Vein occlusion, 636, 3 Vabysmos, and so 6 weeks apart. And I know the loading dose is monthly, but sometimes if I feel that it does last, and to reduce the amount of injections, sometimes we increase it, and that's what's happening. So some diabetic ones, so hard exudates and everything, and swelling. So 2 Vabysmos, 1 month apart, 2 months later, OCT picture is beautiful. And again, as this one is very stubborn, I may add, Kenacort here as well, with another injection, and that usually has phenomenal response, So DME with CMO, 2 Vabysmos, 6 weeks apart, and this is how it is. And so there are some stubborn cases, and so this is diabetic retinopathy. One I lost after some vitrectomy elsewhere with endophthalmitis and all. And the right eye, as you can see, there's a very heavy laser done, just besides the fovea. And because of that, there's recurrent CMO. So it was diabetic retinopathy to start with, but this probably, I feel that it's because of that heavy laser the patient is getting. So even with Vabysmo, we can't leave more than 3 months in this patient. Whenever we do, the CMO comes back and it responds better to PST Kenacort. Last one I gave her suprachoroidal Kenacort, and that edema went away for about 5-6 months, and it recurred again. So considering another one, let's see. So that's it. Thank you very much.
Thank you very much, sir. And now we'll have a panel question answer time with panel. And I would like to invite Zarul Mazri Saab, Suhail Sarwar Saab, Dr. Suhail Shehzad Saab, and Rizwan Saab, please.
These few days difference makes, when I studied the Vabysmo, that how does it clear the edema or improve the vision in less than in few days. Then I came to know that it is a biphasic molecule that acts on anti-VEGF as well as on anti-angiopoietin 2. This angiopoietin 2 effect, it decreases the edema in interstitial fluid or where there is a fluid collection. So this is the part of the Vabysmo that helps in improving the vision in less time. So for the other parts, other panels.
Another side of that picture, certain decrease in the different fluid can cause the RP. How many kids have seen
No.
the RP risk? One of the two form of RP risk.
No, I didn't see any case of RP rape in my patient.
So my next question will be from Professor Zarul Mazri Saab. Sir, what is the protocol you follow in your practice?
Myself and Dr. Khurram Mirza share operation theatre, and we are having chat on these subjects almost twice or thrice a week. So most of my protocols are what Dr. Khurram Mirza is following, and most of my patients, my experience with Vabysmo is, but first I need to answer Dr. Tariq Khan's question. Why did I start Vabysmo? You see, whenever a new molecule is launched, or a new product is there in the market, it comes with certain claims. And most of those claims are originating from their evaluation studies, from their approval studies, or what the companies intended to do. And what was gained in real world, most of those data is coming from Western countries, from America, from Europe. So there is always an excitement. Every new addition to our armamentarium is a welcome thing, because it has certain indications. Even Patizra is not ruled out yet. It has certain indications. For example, Dr. Khurram Mirza is doing a lot of ROP, and the preferred drug for the kids is still ranibizumab. So addition of molecule is always welcome thing. So when a new molecule comes, we have to see it, that whether the claims are justified. The drug came with very high claims that the duration, first the claim was that lesser injections will be needed even as a loading dose. But in real world trials, it did not prove right. So the loading dose is almost, sometimes some people say 3, some people say 4. I am using 3 injections as a loading dose in neovascular AMD, and about 4 to 5 injections in diabetic macular edema. And as has been mentioned, in vascular occlusions, I am adding now treatment naive patients to Vabysmo as well. And what I feel is that in massive edemas and leakages, for example, even in neovascular AMD, if there is massive exudation and leakage, the role of Canacort is not stressed, as we have felt it in our practice is useful. And most oftenly we add posterior subtenon Canacort instead of injecting in the vitreous. And we feel that the side effects are less and the response is excellent, and it helps to decrease the need of number of injections quite significantly as long as anti-VEGF is concerned. So the first patient I shifted to Vabysmo was a patient who was there with us since 2021. And in 4 years, he was having ILIA, and one eye was settled on 3 monthly injections, but the macular edema kept on coming back in 2 to 3 months. So it was varying. Sometimes we were injecting bi-monthly, another year 3 monthly. And when this Vabysmo came, there was dramatic improvement. One thing that he responded just within 2 weeks, that I'm feeling better now. Second thing, that he is happy for last 1 year or so on 4 monthly dose. Now simple, we are giving him Vabysmo every 4 months, and he doesn't call. And sometimes I ask my assistant, where is that patient lost? Ask him. So he's quite happy. That was the first patient. And now treatment naive patients we are adding is mainly vascular occlusions, and even we can observe with single injections. But I always say, like in glaucoma sessions, go for the panoramic picture. There is no magic. No drug is a perfect cure. You have to keep your eyes open. You have to really interact, really explain the prognosis and the long course the patient is going to need. So the financial burden, everything we need to share, that it's not a matter of 1 month, 2 months, or 3 months. The rest of your life, you need to have a good relationship with the ophthalmologist. So these things are important, and this is what I wanted to share about my experience with Vabysmo.
Thank you very much, sir.
I want to extend Dr. Zia's experience. The role of Canacort in the presence of non-responding anti-VEGFs. He uses posterior subtenon. I uses suprachoroidal. So my choice is not posterior subtenon, suprachoroidal, with particularly if the patient is aphakic and not responding to anti-VEGFs. So
Aphakic or pseudophakic?
Pseudophakic. Pseudophakic, and patient is not responding to anti-VEGFs, then I add suprachoroidal Canacort, and I use precipitated triamcinolone and inject 0.05
You're
ml.
talking about the vein occlusion.
The
vein occlusion.
No, for DME as well.
Yeah.
For DME as well. And the second thing is Dr. Zia Mazri highlighted is that he is using loading doses plus 4 monthly doses. This is a different regimen. I use regimen that is loading dose with treat and extend regimen. Treat and extend
How many
regimen.
loading doses?
3.
In both the cases in DME?
Yes,
But
in
the
both cases.
But the protocol is different.
Yes, protocol is different, but I use always the loading dose.
Okay.
Loading dose. Even if the
Loading
patient
dose
has
will be
responded
amount
after
different.
first injection, I always give the 2 loading dose as well. And then I shift to treat and extend module. Treat and extend module is that you do repeatedly OCTs, and if this macular edema appears on OCT, then you will treat it.
छोटा सा एक है कि ये जैसे प्रोफेसर सोहेल ने कहा कि पोस्टीरियर सबटेनॉन इंजेक्शन की बजाय वो सुप्राकोराइडल देना पसंद करते हैं, तो वी हैव मेड इट 3-step approach as long as Canacort is concerned. We combine it with anti-VEGF with posterior subtenon. If the patient doesn't respond to the first injection on 2 monthly OCTs, then we go for suprachoroidal. और हमारे लिए कोई रास्ता भी बंद नहीं है. जो सुप्राकोराइडल को रिस्पॉन्ड नहीं करता उसको वो बादलों का सारा सुना के कि कुछ अर्सा रहेंगे उड़ते क्लाउड्स रहेंगे सामने, तो हम इंट्राविट्रियल भी यूज़ करते हैं. लेकिन दिस इज़ हाउ वी हैव ग्रेडेड इट फ्रॉम 1, 2, 3 steps. So rarely we use intravitreal. Quite often we perform posterior subtenon, and sometimes we do suprachoroidal as well.
Suhail, I have a question for you. When you say that treat and extend, when you see edema on OCT, is there a minimum central macular thickness? That you
Yes. It's about 300 microns.
300 microns.
300 microns.
Change.
300 microns, or generally, if the cyst, sometimes the fovea is not involved. The extrafoveal spaces, they are more involved than the fovea. Fovea is generally spared in few cases. Then I qualitatively
Let's talk about central
left. Yes,
macular
central macular thickness. Yes, 300 microns.
300 microns.
300.
I think Professor Khalid is asking कि कितनी चेंज के ऊपर आप treat and extend का इंजेक्शन नहीं लगाएंगे. 300 तो अगर 600 300 माइक्रोन था, तो अगली दफा 600 होगा तब आप लगाएंगे कि 350 होगा तब लगाएंगे.
350.
So this is what I think Khalid Saab was asking. If 50 microns thick change, any change which is like 50 microns in central thickness, that is significant
and the
for you
second-
to either give injection or wait for the
And the other thing is deterioration in VN. Deterioration in VN.
सब क्वेश्चन थोड़ा डिफरेंट है. हम ये नहीं कह रहे कि लगाएंगे, हम कह रहे कब तक आप नहीं लगाएंगे.
कब तक नहीं लगाएंगे जब तक VN deteriorate ना हो.
microns में 50 microns I think in the sense
मैं
15 microns change.
UK गाइडलाइन बता दूं कि 400 माइक्रोन थिकनेस से कम पे यू कैन नॉट इंजेक्ट एनी intravitreal anti-VEGF on NHS. So if somebody, even if their vision is slightly disturbed and they are symptomatic, they have to go privately to get the injection. They get so minimum central macular thickness has to exceed beyond 400 microns.
ये तो उनका
That is more a financial. That is more a financial problem.
Otherwise, the patient needs an antibiotic.
This is a financial NHS burden, basically.
And secondly, I mean, wherever doctor
देखिए अवेयरनेस होनी चाहिए ना हम सबको कि हाँ वो फिर हाँ अब ये कि आप मतलब एडीमा सटल एडीमा पे भी नहीं लगाएंगे जाहिर है. तो आपने वही मैं फेल से ये भी पूछना चाह रहा था कि इसका क्या क्राइटेरिया है कि 350 पे लगाना है जब स्टार्टिंग सेंट्रल मैकुलर थिकनेस जो है वो किस पे आप कहोगे यार इसको लगाना चाहिए.
देखिए मैकुलर थिकनेस जो है ना वो मेरा सेकंड रेफरेंस पॉइंट है. फर्स्ट रेफरेंस पॉइंट है जिस पेशेंट को आप ट्रीट कर रहे हैं और उसकी वीएन इंप्रूव हो गई है और स्टेबल है. व्हेन ही फील्स डिफरेंस इन वीएन वो खुद आता है लगवाने के लिए, और फिर जब हम ओसीटी करते हैं तो जब उसमें चेंजेस उसको भी नज़र आती हैं तो तब वो कहता है कि जी गो फॉर इट.
And sometimes I think vision is more important.
Vision is
मेरे पास एक पेशेंट ऐसे आता था, वो सीट में गया, ये ड्राई कहते नहीं डॉक्टर विजन में अब लगा दे, उसको लगाया तो विजन improve. And secondly, I think the vision should be on a top of the list. And then और एक और बात है कि आपने absolutely dry नहीं करना मैकुला. You dry absolute macular dry, वो आपका degeneration में चला जाएगा, क्रैक हो जाएगा.
और तो बात यही है कि we have to treat the patient,
Yeah.
not the anatomy.
और ये जो है ना कि हम कह रहे हैं कि विस्मो हम नहीं कर रहे, तो बाहर के मुल्कों में विस्मो होगा. मैक्सिमम जो एंटी-VEGF अमेरिका में लग रहे हैं, दैट्स द बेस्ट है।
Yes.
अब आप शायद
अमेरिका में नहीं, पूरी दुनिया में लग रहे हैं।
पूरी दुनिया में वैक्सीन सब
दुनिया में
टॉप पे लिस्ट है। नो प्री-फिल्ड के अलावा भी हैं।
वो
मैं आपको बताता हूँ कि सबके नाम बता
इसकी
सकता
वजह
हूँ।
कॉस्ट
आई
है।
कलेक्ट जब इन्होंने मुझे
इसकी
कहा
वजह कॉस्ट है, क्योंकि इंश्योरेंस कंपनीज जो हैं वो उनको वैक्सीन को अफोर्ड कर सकती हैं और वेवेस्मो को नहीं कर सकती अफोर्ड। ये बहुत बड़ी कॉज है, तो बहुत बड़ी वजह है।
इवन इन जब इन्होंने कल रियल वर्ल्ड डाटा किया
I think, sir, can we get into the session before it starts? So my question would be from Dr. Rizwan. What is the DME protocol that you follow at your institute?
Assalamualaikum. I am Dr. Rizwan, Head of Ophthalmology at Faisalabad Medical University and its allied teaching hospitals. We started late with Vabysmo from June 2025, and we did not switch any injection. And so far, we have enrolled around 14 patients, and we usually give 2 injections at 1 month interval, and then follow the individual treatment response on OCT and best corrected visual acuity. That's
All right, thank you. So my next question would be from Dr. Shahzad sir. Is retinal drying important for improved visual outcome?
is what
Yes.
Retinal
Retinal
drying. Drying. Not drying, DRAW, not this DRY. Yes, retinal drying is very important. The fluid is the only factor, I think, that is main structure, causing structural damage to the photoreceptors and the other cellular layers. Yes, we have to make the retina dry, and we keep the retina dry for a longer period of time. By which way you can, there's a lot of confusions in some cases, but I think that should be individualized, and it's not basically some kind of a evidence-based practice, as Dr. Mazri was saying. I don't agree with that, if there was a new injection and I have to inject that. I think that it must be some evidence-based practice, and we must have some strict criteria for switching. Why to switch? And the most important indication is when there is a suboptimal response. When you are injecting some kind of safe anti-VEGF and you are going to switch it, you think there is suboptimal response. And here comes that when the thickness doesn't reduce, there's no improvement of more than 5 letters, and there are other things, then this is a suboptimal response, and you have to switch the drug. Second thing is when there is you are injecting Eylea and other injections, and there is a term called fatigue of treatment. We also call it the tachyphylaxis. Tachyphylaxis is when there is a worsening of response. That once the treatment has started and there's some improvement is there, but after some time there is some worsening. It means there's some other factors was working. That may be angiopoietin, and you can in that particular case, if you will shift from Eylea to Vabysmo, there must be a definite response, and that might be one cause. That's the only cause that I'm thinking about of your 57 cases. That was not your cases. That is the only possible academic cause. Otherwise, I think the injections were not there. 57 injections were not given in that particular patient. There might be some angiopoietin 2 was involved. That's the reason that Faricimab worked in that particular case. That might be one reason. So yes, this is the second important thing. Then when we have to shift the drug, we have to switch the drug, there must be something you have to prove that by your switching. Third thing is that very important factor that as Qasim was also saying, that after every 8 weeks, you have to re-inject Eylea. I have not seen a case of AMD where you can go beyond 12 weeks. I have seen only few patients, and a few patients were 16, 18 weeks, and those are those patients where had some kind of bleeding episode was there, and that caused a scarring, and that scarring resulting into the CNV, end of CNV. So that I think that you have to shift the drug from, switch the drug from one to this area. The longevity of the duration of this Vabysmo is much higher than the Eylea, and 7 to 8 injections in 2 years is quite good. That's a very important thing for some patients, for most of the patients, I think.
The Qasim has said quicker, faster, and long lasting.
Khurram Sahab ne kaha.
Khurram Sahab ne kaha. Those beautiful words.
I have at least maybe 12, 13 patients who who were on treatment and they were almost settling down when we converted them to Vivismo. But before that, I knew that every time we wanted to go above 2 months for Eylea and others, it would recur. But now I'm reaching 4 months with this. So I think some of them will stay on 4 months. There's 1 or 2 here I mentioned that we'll go on to 5 months. Let's see what happens. But 4 months, yes, we have reached a few of them.
After 3 loading dose, you directly switch.
No. Treat and extend is what I follow as well. And
After 3 loading dose, you go for the 8 weeks.
then I go for 8 weeks, and then 12. Not at all.
And you never go to NBT, need-based therapy. NBT, need-based therapy, that patient used
No,
to tell.
yeah, that's SOS or NBD. So PRN. So
Need
in
based
those,
or treat and extend एक ही है.
Some
Yeah.
of my patients are on NBT.
Yeah.
And they are working fine.
that's fair enough if they are doing fine. But overall, we've seen with Eylea actually that whenever we went to SOS regime, there was more recurrence. And once there is recurrence, you're bound to give few frequent ones. With this, it slowly closes down, remains closed. So more and more patients will have less recurrence.
I think you should tell the patient, give him the Amstelgrid.
Yeah.
वो Amstelgrid regular use करें. Whenever there is a change, you go for the injection. जैसे whenever required. जो है ना कि हमने 4 महीने बाद लाजमी लगाना है. I think in our part of the world it's different. जब मैंने start किया, जब वो आए मेरे पास, for the first few months, I was never convinced कि Vivismo भी लगाना है मैंने. But mostly, I'm treating those patients for switching. And then I've also seen a case of CSR, जिसको Eylea 2 लगे थी, respond किया, and there was a raised area PED का, and then I gave Vivismo and he responded very well. ये मेरा photograph है. Secondly, जो हम सब बैठ के भी discuss नहीं कर रहे, is the price of the injection. How do you convince up there the patient to give 20,000 more than Eylea? आप कैसे convince करते?
Me?
Anyone?
Sir, now
I used to explain in a different way.
Okay, how many are responded? The commonest disease in our part of the world is DME and not CME.
Yes.
ये हमने study किया, हमारी study published की है. बाकी दुनिया में CME is on the top of the list. हमारे यहाँ DME है. And DME are those patients जो पहले afford नहीं कर सकते. अमीरों की तो बीमारी रही नहीं है. ये गरीबों को.
For DME, there's a combination.
Yes.
We must have to understand we are not Europeans, we're not Americans. We are here, we have cost
जहाँ
problem.
पे PRP है वो PRP
Yes.
करते हैं. ये जो है ना ग्रिड लेजर और उसका है.
Sir,
हम एक गलत कॉन्सेप्ट लेके
नहीं, we don't have a-
वो लेजर नहीं लगाते. All of the world, the PRP is on the top of the list.
Sir, in diabetic retinopathy,
Yeah, I'm
one
diabetic
major factor is the control of diabetes.
Yeah.
If the patient is not controlling diabetes, then कुछ भी नहीं होगा फिर. Second thing is that there's inflammation is going
आपको
on.
याद होगा when we went to the Turkey, उन्होंने कहा जो नैन्सी से मिली
Yes, exactly.
कि आप अगर शुगर नहीं, वो कहती प्रोटोकॉल M का मुझे बता दिया.
हाँ.
And then we went back and studied protocol M. It was entirely different thing what the company manager was saying.
Second thing is inflammation control. Inflammation control is only by steroids. We must have to
Control of
understand,
diabetes is the most
after diabetes control, we must have to control inflammation inside the eye. We need an injection Scanacort until unless कि patient को कोई glaucoma का chance है. और मैं कहता हूँ कि अगर इतनी inflammation है, for example अगर उसके साथ
Diabetic
kidney
patient.
और diabetic patients.
I think diabetic patient का cause of inflammation is hyperglycemia.
Yes.
You control glycemia, आपको कहना कॉर्टिक जरूरत ही नहीं पड़ेगी.
उसके बगैर तो मसला नहीं
और
आता.
कितने केसेस में आपने suppose
Sir, then
आपको जरूरत पड़ी है कहना
then
लगाने की.
1, 2, 3 Vivismo or Eylea whatever and laser. इससे ज़्यादा उसकी ट्रीटमेंट नहीं.
अब मैंने जब ये गूगल सर्वे किया है, most of people they are not knowing about Vivismo, they are not using Vivismo. It's a very small percentage, and again switch करना is because of the cost effective.
It's very difficult to switch in diabetic
पर रिएक्शन
patients.
का पर इसलिए हम सब बैठे हैं जो नहीं कर रहे या जो करते हैं. अब मैं तो करता हूँ, मैं तो
आप सर मल्टी डोजिंग कर रहे हैं
मल्टी डोजिंग कर रहे हैं.
और कितनी इस पे डोज कर रहे हैं?
इसमें 2 था.
थर्ड नहीं करते.
मैं 3rd नहीं बनाता.
यहाँ पे दो ही कहा
बनाते हैं
जाए,
ना,
डायबिटिक
यहाँ पे दो ही कहा
है ना, उसमें जो
लेकिन कंपनी नहीं कहती तो
ऑफ लेबल
जो एक चीज हम बिल्कुल इग्नोर कर रहे हैं डायबिटिक मैकुलर एडीमा में, आई थिंक
वो तो कहते हैं एक वाइन एक काउंट पे
हाँ, बिल्कुल।
के लिए दूसरी ले
वापस कर दें, भर के
ठीक है,
देंगे।
इसके ऊपर सिंगल डोज होती है
और ये बाकी कंपनी तो कभी नहीं कहेंगी
कंपनी तो सिंगल डोज लिख के प्रिंट करके देती है क्या चीज
डायबिटिक मैकुलर एडीमा में बात तो
I
सुनिए,
think let's
diabetic macular edema में we are forgetting one thing, that there is now going to be role of micropulse या subliminal laser. We cannot ignore that.
उसका
So,
मैकेनिज्म क्या होगा एक्शन का?
मैं बता देता हूँ आपको मैकेनिज्म ऑफ एक्शन। माइक्रोपल्स में जो होता है
पुराना है आरपी फंक्शन,
बेसिकली इट एक्साइट्स, वो आपको जब आप फायर कर रहे होते हैं यू शुड नॉट बी एबल टू सी इट, ठीक है, ज़ाहिर इनविजिबल है ये, और उसका क्राइटेरिया ये है कि आपने पहला शॉट जो है विजिबल शॉट देखना है, और उससे 50% पावर लेस करके 160 माइक्रॉन्स स्पॉट साइज रखना है, एंड देन यू फायर अवे। आप पूरे मैकुला को
लेकिन
फोबिया पे नहीं लगाना, लगा सकते हैं लेकिन लगाना नहीं
नहीं, फोबिया पे
अब मैं आपको बता दूं उसका मैकेनिज्म ऑफ एक्शन ये है कि इट एक्साइट्स द रेटिनल पिगमेंट एपिथेलियम एंड द मुलर सेल्स, एंड दिस इज द वे इट हैज एन एंटी VEGF इफेक्ट। ये है, ये तो दुनिया में हो रहा है। डायबिटिक मैकुलर एडीमा के कॉन्टेक्स्ट में if you have a combination treatment, combine subliminal or suprathreshold laser with anti-VEGF, you will get the best results.
Thank you, sir. I think we'll have the last comments from Professor Rashid.
थैंक यू वेरी मच, थैंक यू वेरी मच। 1 घंटा बैठ के और मुझे कुछ टाइम दीजिएगा, सिटिंग फॉर 1 आवर। एक तो ये था कि आई वाज थिंकिंग, इतने माशाल्लाह, आई एम थैंकफुल टू ऑल द पार्टिसिपेंट्स कि आप लोग तशरीफ़ लाए, दैट्स प्रॉब्ली वंडरफुल सेशन। मैं सोच रहा बैठा हुआ कि ये आखिर ये आप लोग क्यों आए हैं, तो कुछ तो मिलना चाहिए आपको। एक तो मैं काफ़ी ज़्यादा तारिक खान साहब से बड़ा मुतफिक हूँ कि ये हमें पहले तो ये अवेयरनेस देनी चाहिए कि ये व्हाट इज़ दिस ऑप्टिमल, अल्फाज लिखे जाते हैं लेकिन मेजॉरिटी ऑफ अस डोंट नो व्हाट इज़ ऑप्टिमल रिस्पांस, सब ऑप्टिमल रिस्पांस, सक्सेस फेलियर है क्या, ये डॉक्यूमेंट होनी चाहिए। कहीं 300 है कि 400 का, आपने देखा कन्फ्यूजन। हम चाहते कन्फ्यूज़ होकर आप यहाँ से न जाएँ आज। नंबर 2, बात की सर चूँकि हमारे एक शायर हैं, तो उन्होंने कहा जी कि वो जो भी नई ड्रग आएगी उसको इस्तेमाल तो करना है, ठीक है। तो नोबडी नहीं ओ सर, मैं किसी और गल कर लगा, ओ सर मैं शायद नहीं, मैं तो कोई और गल कर रहे हैं। तो मेरा ख्याल ये था कि मैं कि जब भी नहीं मैं आपके लिए हेल्प कर रहा हूँ कि जब भी कोई नई ड्रग आती है लोग हमें उसके लिए देते हैं सैम्पल्स, तो आप हमें सैंपल दिया करें, ठीक है, इसलिए मैं आपके लिए फेवर कर रहा था। अच्छा सर, अब ऑन द सीरियस नोट, ऑन द सीरियस नोट, ओ नहीं सर, तो सैंपल मिलने चाहिए था हमें, ठीक है जी, इसलिए सर आपको सैंपल मिलेंगे, आप फिक्र ना करें आप।
मुझे मिले थे
अच्छा ऑन द सीरियस नोट, हम जब भी बात करते हैं एडीमा रिकर्स, हम जब भी बात करते हैं विजन गोज डाउन, तो जहाँ पे इंजेक्शन की बात है हम फोकस चूँकि आज वेबिस्मो पे कर रहे हैं, हम कहते हैं कि जो ही एडीमा रिकर करेगा या विजन कम होगी, यू शुड गो फॉर दी स्विचिंग ओवर और यू शुड गो फॉर नेक्स्ट इंजेक्शन। मेरा ख्याल ये है, बात ये मजरी ने की थी, अब इन फेवर ना हो ताकि थोड़ा गुस्सा ठंडा हो, कि यू शुड लुक इनटू सिस्टमिक फैक्टर्स एज वेल। हम बहुत ज़्यादा तादाद के अंदर ऑप्थेल्मोलॉजिस्ट, हमारा फोकस सिस्टमिक इवैल्यूएशन के ऊपर नहीं है। HbA1c जो जितनी स्टडीज़ आप पढ़ लें, HbA1c तारिक खान साहब इसको सेकंड करेंगे, HbA1c कितना होगा 7.5, हमारा HbA1c कहाँ होगा 11.5। तो जब 11.5 पे आप लगा रहे हैं, आप जो मर्जी लगाते रहें, एडीमा रिकर करेगा वंस यू स्टॉप इंजेक्शन। तो जब तक आप सिस्टमिक इवैल्यूएशन नहीं करेंगे, HbA1c नीचे नहीं लेके आएंगे, इट डजंट मैटर कि वेबिस्मो है, वेस्टर्न है या पिटिजरा है। दूसरी बात, जो अहम बात है जो आज मैं कहना चाह रहा हूँ, वो ये है कि जिस तरह हम कहते हैं कि इन्फेक्शन डजंट अफेक्ट द रेटिना, इट्स इन्फ्लेमेशन दैट डैमेज द रेटिना। सिमिलरली इट्स द फ्लूइड दैट इज डैमेजिंग द रेटिना और द मैकुला, द फोटोरिसेप्टर्स। इट्स बेसिकली द स्कारिंग, रिप्लेसमेंट ऑफ फंक्शनल टिश्यू इनटू नॉन फंक्शनल स्कारिंग टिश्यू। ये बड़ा इंपॉर्टेंट फैक्टर है। ये जो आपके पास ERM बन जाती है, फोटोरिसेप्टर लॉस होता है, और वो जो वर्ड बोला खुरम ने कि फास्टर एंड स्ट्रॉन्गर, तो वी नीड ए फास्टर ड्राइनेस ऑफ द मैकुला। हम इस पे वेट नहीं कर सकते, एक लगाया 2 लगाया बैठे हुए लेके। जितना फास्टर करेंगे उतना फोटोसेप्टिक स्कारिंग कम होगी, उतने विजुअल आउटकम ज़्यादा बेहतर होगा। तो ये जो एंटी स्कारिंग मैकेनिज्म है बिस्मो का, प्रॉब्ली इसको हाईलाइट नहीं किया जा रहा ज़्यादा। प्रॉब्ली जो बात की बीच में ILM की प्रोफेसर इसने, आपने भी की, मतलब आपने की थी खुरम साहब, उसके बाद ये बात की थी, इस तरह फोटोसेप्टिक स्कारिंग भी होती है, फोटोसेप्टिव लॉस हो जाते हैं। इन 2 बातों को फोकस कीजिएगा कि बिस्मो जब भी लगाना है आपने, स्विचिंग ओवर किस पे करनी है, ये तो आपने सुन लिया कि जब आप स्टक हो जाते हैं यू हैव टू स्विच ओवर। आप काउंसलिंग कैसे करेंगे पेशेंट की? मेरा ख्याल ये है कि जब आप कॉस्ट की बात करते हैं तो कॉस्ट के लिए आपको काउंसिल करना पड़ेगा। यू कैन काउंसिल एनी पेशेंट। अच्छा, अब ये आपके ज़िम्मे है कि आपके दिल में कहाँ पे कहाँ तक सारे जहाँ का दर्द मेरे जिगर में है, कि आपके दिल में कहाँ आता है कि यार मैं काउंसिल तो कर बैठा हूँ इसको, लेकिन कहाँ से पैसे लेके आएगा। देन probably either I go for a good force angiography and follow my friend for micropulse laser, or I go for the Canacort usage if it is diabetes. RVO is a different concept. RVO is event-based edema. Diabetes and AMD is a continuous progressive disease. ये रुकती नहीं है। RVO अटैक हुआ, इवेंट हुआ, चला गया, you can manage it as speed you manage it and you get it done. तो you can have a combo of both anti-VEGF and steroids both. अब इन चीज़ों को देखते हुए मेरा ख्याल ये है कि आप जब तक बिस्मो वालों, भाईजान आपसे जब तक आप हमारे इन तमाम डॉक्टर्स को मुझ समेत अवेयरनेस नहीं देंगे कि व्हाट इज सक्सेस ऑफ इंजेक्शन, व्हाट इज फेलियर ऑफ इंजेक्शन, व्हाट इज ऑप्टिमल रिस्पॉन्स, व्हाट इज सब ऑप्टिमल रिस्पॉन्स, और व्हाट इज द मैकेनिज्म ऑफ स्कारिंग। देखिए, मैं अक्सर सोचता हूँ बैठ के, मुझे पता मेरे दोस्त कहेंगे, तारिक साहब हमारे सीनियर बैठे हुए हैं, कि सब टिरान इंजेक्शन स्टीरॉयड जब भी देंगे ऑर्बिट के फैट की ट्रॉफी करेगा वो। सब टिरान इंजेक्शन ऑर्बिटल फैट की ट्रॉफी करेगा वो, आज नहीं तो कल कहीं उसकी आंख संकन होगी। तो मेरा ख्याल ये है कि आप जब ये कहते हैं कि किसी को अभी कासिम ने कहा एक पेशेंट 82, आपका पेशेंट था 82 ईयर्स का, कितने इंजेक्शन? 69 इंजेक्शन स्क्लेरा से लग गए हैं। उस स्क्लेरा से पूछो भाई तेरा हाल क्या है। तो इट्स वेरी डिफिकल्ट कि हम हर चीज़ को लगाते चले जाएं। हमें बहुत सी चीज़ों को, जो मसरी ने कहा, कि एक सिस्टमिकली एज अ पेशेंट देखना पड़ेगा और उसके लिए अवेयरनेस कैंपेन चलानी पड़ेगी। इंजेक्शन लगाना आसान काम है, काउंसल करना आसान काम है, लेकिन इन तमाम चीज़ों की अवेयरनेस जब तक नहीं होगी उस वक्त तक प्रॉब्ली हम कहीं ना कहीं फॉल्टी डेटा में रहेंगे। वो फॉल्टी डेटा होगा आपका अपने लिए, मेरा अपने लिए। Thank you very much.
Thank you, sir. We're running short of time, sir. I'll have last comment by Mr. Tariq Aziz, sir, and then we'll wrap up the session.
Thank you very much. The other thing I wanted to ask you, Khurram Saab, that you mentioned that you mixed the Vabysmo with Canacort and all that, and I'm also thinking of moving to that thing. It responds better with non-responders. So, do you mix the dose together, or you do it separately? This is a little bit of confusion here. Okay. No suprachoroidal. No.
If I have to increase the dose of less response or recurrent macular edema, usually I give those in vein occlusions.
Okay.
And like we were all mentioning, I wanted to say that as well, it's an opportunity. Most inflammation occurs in vein occlusion because vein occlusion is a sudden insult to the retina.
Yeah.
So there's most inflammation going on, and without that, number one, it helps reduce the edema quickly with vitreal anti-VEGF. Number two, it reduces inflammation, will cause less scarring. In diabetic edemas, it helps as well. Sometimes when I see AMD with hemorrhage, if there is hemorrhage will cause more scarring, even with resolution. So these are some selected cases where I tend to give Canacort, initially, and then see how things go. And so for very stubborn CMOs, then I try to go for suprachoroidal.
I fully endorse your point that you said that vein occlusion is always a headache for us, and no doubt the Vabysmo response is excellent in those cases. No doubt about that.
Thank you very much for your comments, sir, and we had a very good discussion. Now I would invite all the panelists and the chairpersons. Cake cutting is in 1 year. They're celebrating their 1 year, and I would request you guys to kindly come at the back of the session so that we can cut the cake. Thank you.